My name is Larry Goldstein. I'm the chair of neurology at the University of Kentucky and the associate dean for clinical research. And I also was the chair of the writing committee for this scientific statement that focused on aggressive LDL lowering and its potential complications. My vice chair was Dr. Peter Toth, and who will introduce himself.
Hi, I'm Peter Toth, and Director of Preventive Cardiology at the CGH Medical Center in Sterling, Illinois, and also Adjunct Professor of Medicine in the Division of Cardiology at the Johns Hopkins University School of Medicine.
I wanted to start out with is what generated this particular scientific statement. I'll summarize it first, and then Dr. Toth can add to that. We know that statins and other medications to lower cholesterol levels, lower lipid levels, have a dramatic impact in reducing the risk for cardiovascular disease in general, but cardiac disease and stroke in particular. But there's a problem. The problem is that these medications are not used as widely as they should be. There's a tremendous gap between the prescriptions for these medications and the numbers of patients who could potentially benefit from them. One of the reasons for that is concern about potential side effects of lipid-lowering medications. So that was the basic background for why this scientific statement was commissioned by the Heart Association. There are some very specific details about it that maybe Dr. Toth could expand on a little bit.
Yeah, so we know that LDL cholesterol management is an extremely important facet of risk reduction in the setting of atherosclerotic disease. And we have well-defined goals for LDL reduction for patients who are high and very high risk. And these goals are less than 70, less than 55. In Europe, if you have an event within 2 years of an incident event, they're now recommending an LDL of less than 40. Now, for some reason, these numbers make people a little nervous because there is this misconception that if you drive LDL, quote, too low, then you increase risk for dementia and possibly for hemorrhagic stroke, which of course are very dreaded potential consequences, which we want to avoid. The only problem with this is they are misconceptions. And when you look carefully at the prospective randomized clinical trials, the gold standard upon which we rely, this concern really is not borne out. And hence, when you look at very high-risk patients getting to an LDL target of just less than 70, only 20% typically reach that target, never mind 55 or less than 40. We know that LDL is spent garbage lipid. The better you are at clearing it from your systemic circulation, the lower your risk for cardiovascular events. And one of our goals in promulgating this manuscript was to provide reassurance and help to increase goal attainment rates, because we know that failure to do so means higher risk.
So a little bit about the methodology, about how we approach this. We had a writing group that included 7 experts in the field. We performed a series of different literature reviews to identify relevant literature, both randomized controlled trial data, but as well as observational data. We then synthesized that and also then examined the bibliographies of those reports to try to make sure we weren't missing anything, and then assemble these into evidence tables that summarized the available information in each one of these areas. To start out with hemorrhagic stroke, which was one of the focuses of the report, why the concern about lipid lowering and hemorrhagic stroke? Well, it's based upon, first, epidemiologic studies that suggest that having a lower lipid level, total cholesterol and LDL, is associated with an increased risk of hemorrhagic stroke. But that's different than having a cohort of patients who may have an elevated lipid level and then have that level lowered. So in primary prevention, folks who haven't had a stroke or myocardial infarction but are at risk because of a high lipid level or other factors, there's virtually no evidence that lowering lipid levels, even to very low levels, increases the risk of brain hemorrhage. In patients who have had prior cerebral vascular disease, have had a prior stroke, the data is a little harder to work through because there is some evidence from secondary analyses or smaller analyses of randomized trials that there may be a small increased risk of hemorrhage, although that also is debatable. However, I think the important point here is that even with that, the dramatic reduction in other vascular events, ischemic stroke, myocardial infarction, way outweighs any small risk that may be associated with statins. The other lipid-lowering agents that are available, however, either added to statins or alone, don't further increase that risk. So despite driving LDLs to very, very low levels, there's very little evidence, even in that population, that doing that increases risk dramatically or in a way that would outweigh the benefits of lowering lipid levels. Dr. Toth?
Yeah, Larry, and to that point, I think we can look at 4 very important prospective randomized studies: TNT, which you were a very strong part of, TST, and then also FOURIER and Odyssey outcomes. When we looked at TNT, there appeared to be a signal for hemorrhagic stroke, but in the end, when you controlled for uncontrolled hypertension or prior history of hemorrhagic stroke, any relationship to LDL disappeared. In the TST trial, there was no relationship to attained LDL even into the 40s or 50s and risk for hemorrhagic stroke. And then in Odyssey outcomes and in FOURIER, where they coupled a PCSK9 monoclonal antibody, either evolocumab or alirocumab, to a statin, and took LDLs to even ultra low levels into the teens or even less than 10, neither of those studies demonstrated any augmented risk for hemorrhagic stroke, irrespective of the attained LDL level.
So the second area that we focused in on was the potential cognitive effects of lipid lowering and statins in particular. There are FDA reports that are uncontrolled from the drug surveillance system of individuals reporting issues with memory or thinking after beginning a statin. On review from meta-analyses and other studies, it's not specific to statins. That acute effect may be associated with any lipid-lowering therapy. Now, importantly, longer-term effects, is there evidence that statins or other lipid-lowering treatments increase the risk of Alzheimer's disease or other related dementias? And the answer to that from the review that we did was that there isn't any credible evidence that lipid lowering with statins or other medications increases the risk of developing Alzheimer's disease or other major cognitive impairment. The next is in patients who have established Alzheimer's disease or other forms of dementia or cognitive impairment. Does the use of a statin or other lipid-lowering medications make that worse? And the answer to that also is no. So when we look at all of the available data, there really is no strong, credible evidence of a long-term impact of statins or other lipid-lowering medications on increasing the risk of cognitive impairment, even in subgroups that are at higher risk. What we hope for would be that actually be benefit of statins in reducing cognitive impairment. The idea or the thought is that since statins do reduce the risk of stroke and other cerebral vascular events, and those are associated with cognitive impairment, that by preventing those, you then prevent the risk of going on to develop dementia. Unfortunately, the data for that is really pretty thin also. Might statins have, and other lipid-lowering therapies, have an acute effect on thinking and memory? Possibly, but there is no evidence that there is a long-term detrimental effect of these medicines on cognition. So the benefit, again, will way outweigh the risk. But again, Dr. Toth, if you want to expand on that.
It's very interesting now that we are honing in with finer granularity into risk factors for the development of Alzheimer's and other types of dementia. It's amazing to me how multiple prospective longitudinal cohorts from around the world now identify hyperlipidemia, hypertension, chronic heightened systemic inflammatory tone, diabetes, metabolic syndrome. All the risk factors for heart disease appear to also be risk factors for the later in life development of dementia. Hence, when you look at some of the early observational studies which suggested that lipid lowering or statin therapy per se may augment risk for new onset type dementia, there was tremendous confounding by not controlling for risk factor covariates that may impact your findings. And now when you look at a study like Ebbinghaus, which was a sub-study of the Fourier trial, where once again they lowered LDL to even less than 10 using a very sensitive cognitive battery, they were unable to demonstrate that there's any relationship whatsoever between baseline and then follow-up scores measuring different facets of cognition, even when LDL was less than 10. And I think fundamentally we have to remember that LDL doesn't cross the blood-brain barrier. Our brain does not depend on hepatically derived cholesterol or other lipids, either for its structural or its functional integrity. Oligodendrocytes and astrocytes produce all the cholesterol the brain needs for either myelin formation or the cholesterol that neurons require for their own metabolism. And the brain holds on to cholesterol very avidly. The half-life of cholesterol behind the blood-brain barrier is somewhere between 5 and 7 years, depending upon the study you look at. And the only cholesterol byproduct that comes out of the brain is 24S-hydroxycholesterol. So the cholesterol metabolism behind that blood-brain barrier is distinct from either gastrointestinally derived or hepatically derived lipid or de novo lipid produced elsewhere. And we really have to be very careful in discriminating these sources of lipid and conclude that basically the brain has its own lipid and sterol metabolism and it protects it very intensely. And so based on first principles, but also on clinical trials, right now we really have very little reason to believe that LDL lowering adversely impacts the capacity of neurons to process information, or that it promotes neuronal dropout or greater impairment in tau protein or other protein clearance from the brain.
So the other area that we touched on, although we really did focus primarily on central effects of lipid lowering, as we just discussed, the other area that we did touch on is one of the peripheral effects, and that's muscle events. One of the reasons that patients don't tolerate statins in particular is complaints about muscle aches and pains. The incidence of severe muscle complications, for example, myositis or rhabdomyolysis, is quite rare, but does need to be taken seriously, especially when patients have complaints. In the randomized trials, what was found is very little difference in muscle complaints between patients who were treated with a statin, for example, and patients who are on placebo. both groups almost equally complain of muscle aches and pains. Attributing it to a statin is probably not true in the vast majority of patients. But again, we do need to always take those complaints seriously. For first, because we always listen to what our patients are telling us, but also because of the, albeit very rare, episodes of myositis or rhabdomyolysis. But again, Dr. Toth?
Yeah, it's very interesting. So many patients complain about myalgia, and that is the number one side effect attributable to statins. And yet, when you look at prospective randomized studies, especially the N of 1 study, which was published in both the New England Journal of Medicine and the Journal of the American College of Cardiology, there was no statistically significant difference when patients were or were not on a statin in terms of myalgia characterization. Each patient was their own control, and when they were on or they were off of a statin, there was no detectable difference in myalgia, either intensity or the presence of myalgia. And of course, rhabdo, which is a dreaded complication, typically, and I mean typically, only occurs in the setting of a drug interaction, or if someone is very dehydrated and for some reason they went into acute renal failure. Statins and lipid-lowering agents in general are quite safe, and we must exert much greater effort in helping patients reach their risk-stratified LDL targets and not be afraid or exert excess trepidation about the potential for hemorrhagic stroke or for inducing dementia, because as scientists, we're just not seeing that relationship. And so we need to ease up, refocus, and help our patients get to their risk-stratified LDL target.
So to summarize, our scientific statement, which examines some of the more common and more feared potential complications of statins and lipid-lowering medications, really found that there was little risk and that the benefit in reducing stroke, myocardial infarction, vascular death well outweighed this even theoretic risk. And the gap between the use of these medications and the potential benefit is pretty wide. So there is a large population of patients who could benefit who are not taking advantage of these medications or this treatment approach. For those of you who are more interested in some of the details about what we just talked about, I do direct you to the paper itself that was published in the American Heart Association Journal. In there, what you'll find is our complete reference list, which was well over 200 reports. But as I mentioned in the introduction, we assembled those into evidence tables so you can read through and look trial by trial, study by study, the primary findings, the primary study design, which we tried to include in great detail for those of you who are interested in finding out and reading more. I'd like to, again, thank Dr. Toth, thank all of the members of our writing group, and thanks to the American Heart Association for commissioning this paper. It took us, Dr. Toth, about 1.5 years or so from start to finish, which is actually pretty quick for a piece of work that was this involved. But I think that the end product is one that should be helpful for healthcare, but equally helpful for patients. Dr. Toth, anything, last words to add?
I think that was a wonderful, wonderful summary. I also wish to thank the members of the writing committee. They were all outstanding. Everything held together so well. And I do encourage everyone with an interest in this area to read the clinical statement, because it is thorough, it is exhaustive, and I think the conclusions reached by the writing group were very, very consistent with the evidence.
Thank you.
Thank you, everyone, and thank you, Dr. Goldstein.